Good morning, everybody. I'm supposed to say that really loud, and I'm supposed to smile to you all, too. Can you imagine that, me smiling? All right, so I'm going to do that. So take a picture, because here I am. All right, again, welcome to our first ever program partnering with Memorial Healthcare Systems. Yes, MS Views and News partners with different healthcare systems around the country, so that way we can bring to the communities around and let them see what these MS centers have. So we're doing that. Today's program, like I said, is with Memorial Healthcare, and it's going to be a day filled of learning for you, so you get to hear, you know, the different modalities or different disciplines of therapy that they have. For those that do not know, my name is Stuart Schlossman. I too have multiple sclerosis, and this began long ago, and that's why you can ask me about it later on. In the back of the room, I want you all to see Jennifer Falk. She's responsible for a lot of the programs that we do, as she writes like all the grants that we do for all the different programs. And speaking about our grants, everybody, and the amount of programs we do, this year, 55 programs across the United States. 55 programs in 52 weeks. There's a lot of weeks that are doubled up, a lot of time on the road and far away. Again, how many are we doing outside the state of Florida? We're doing programs now in 23 states. 23 states, so that's a lot of crisscrossing around. And we're hitting California a few times this year. In fact, at the beginning of December, I'll be back again. It's big trips, big tiring things to do. Since we first began doing programs in February of 2010, we have now held over 310 programs. I can't say over 320, so I say over 310, okay? So that's a great thing, and again, the reason for this is people need it. We are now affecting thousands and thousands of people just from our educational programs, and again, like I mentioned before, social media, between Facebook, Twitter, YouTube, Instagram, we are now bringing our information to over 50,000 people. Okay, over 50,000 see what we're doing every single day, and this is awesome. So now I want to introduce you to Memorial Healthcare System. So Memorial has Multiple Sclerosis and Neurology Center at Memorial Neuroscience Institute. The MS and Neuroimmunology Center is dedicated to providing advanced neurological consultation and extraordinary care to individuals with multiple sclerosis. They focus on all aspects of the disease, including diagnosis, clinical trials, brain imaging, and laboratory research. They strive to improve the health and hope of MS patients through advocacy, education, and advanced treatment and research. I would like you all to pay attention to the screen here, as we have a 30-second video to show you.
Barbara trusts Memorial Neuroscience Institute to care for her multiple sclerosis. She receives everyday extraordinary care, and you can too, even for the most complex cases. The intensive focus of fellowship-trained physicians and specialists, extensive testing, and enhanced multidisciplinary treatment options means Barbara is back to living extraordinary every day. Make your appointment now at memorialneuroscience.com/ms.
Awesome. That was a quick 30 seconds, right? Might have been 20, but that's good. All right, so everybody see what they have? I mean, that's a great thing. They have a fantastic service to offer, and I'm glad that they are in our community. Our first speaker today, her name is Dr. Madiley Broz. She is a neuropsychologist. She's a licensed clinical neuropsychologist, specialized in clinical neuropsychology and rehabilitation psychology. Dr. Broz has extensive experience evaluating individuals of all ages with a wide variety of neurological conditions within medical, psychiatric, and forensic contexts. Dr. Broz has practiced in medical and university settings, primarily in neurology, intensive neurorehabilitation, trauma, and outpatient memory disorder clinic. Dr. Broz earned her doctoral degree in clinical psychology with a concentration in neuropsychology from Carlos Albizu University in Miami. She completed an American Psychological Association accredited doctoral internship in pediatric neuropsychology and rehabilitation psychology at the University of Miami Jackson Memorial Hospital. Dr. Broz completed her postdoctoral specialty fellowship in neuropsychology at the University of Miami Miller School of Medicine, Department of Neurology. She joined Memorial Healthcare System in 2015. Let's welcome Dr. Madiley Broz.
Thank you, Stuart. So, good morning, everyone. I'm Madiley Broz. Thank you for that amazing introduction, Stuart. So I'm here with you today to discuss the cognitive aspects associated with MS. So a quick overview is that we're going to be discussing especially the difficulties or the deficits encountered in patients with multiple sclerosis. We're going to go through the evaluation process and the test batteries that we usually use, and then how these cognitive dysfunctions affect the activities of daily living. We will be discussing as well the psychological and social impact of these cognitive dysfunctions and what we can do about it, or my recommendations to overcome that. So let's first start by defining what cognition is. Cognition is actually, or thinking abilities, is our ability to focus, maintain, and divide attention. It's our ability to learn and remember things, plan, carry out and monitor activities, think, reason, and solve problems objectively, understand and use language, recognize objects, assemble things together, and judge distances, among many other aspects in cognition as well. They're more specialized. So a brief background on the prevalence and frequency of cognitive changes in MS. Typically, we observe about 75 to 70% of patients with multiple sclerosis experience some kind of cognitive change in their lifespan. These changes typically, the range of these changes typically range from mild to moderately impaired, and it follows a very slow progression, which is gradual. Less than 10% of patients experience deficits severe enough to impact their daily functioning at home and at work. And less than 5% experience dementia related to multiple sclerosis. So the prevalence of cortical syndromes in multiple sclerosis is very low, such as aphasia, apraxia, and agnosia. These is more related to vascular etiologies, or let's say a stroke, for instance. So those functions are not affected, or impairments are not affected in multiple sclerosis for the most part. So the degree of the extent of the cognitive deficits associated with multiple sclerosis really depends on the cerebral pathology, or the brain abnormalities and lesion burden on MRI. For example, tissue loss and atrophy of the corpus callosum and thalamus correlate much more frequent with the cognitive aspects. Regarding the physiology of cognition in multiple sclerosis, like I mentioned, typically when we observe deficits or lesions in the cerebrum, or the outer layer of the brain, which has to do with higher order thinking abilities, and the thalamus, we see more cognitive changes, or at least more pronounced. We're less likely to see cognitive changes if the lesions are in the cerebellum, brainstem, and spinal cord lesions, okay? And that's pretty much a picture right there showing you so that we can familiarize ourselves with the brain anatomy and you're not so lost. So in terms of the cognitive impairments, the first domain that we see affected in multiple sclerosis with a higher incidence of 30 to 60% of cases is in processing speed. So we call this the footprint of multiple sclerosis because it's really the hallmark feature. More intense than memory and new learning, which is 40 to 50%. Memory and new learning follows processing speed for the most part. We see speed of information processing a lot more affected. Then also complex attention, which is an area of executive dysfunction. And the prevalence is 25 to 35%. Then visual perception, or let's say word fluency, 10 to 20%. And then in less than 10% of cases, we see severe widespread deficits, okay? We don't see affected intellectual functioning, in other words, intelligence, okay? Long-term memory, childhood, adolescent memories from the past are not usually affected. Conversational skills, our ability to comprehend language and follow reciprocal conversation, not affected either. Reading comprehension, not affected either. So the first step into actually addressing these cognitive changes is start usually with your neurologist, who would refer you for a neuropsychological evaluation. And this is the use of a battery of standardized tests that are sensitive to brain dysfunction. Unlike a CT or an MRI, which shows abnormalities in the structure of your brain, or an EEG, which shows the electrical abnormalities of the brain, neuropsychological testing actually shows what a person is able or not able to do at a functional level. So it's really putting your brain to work with tasks that we do. It's also a comprehensive way of assessing all of your cognitive abilities. Like I mentioned before, the ones that we think are more affected with multiple sclerosis, and as well as a comprehensive assessment of all those cognitive abilities that you see there, including verbal, memory and learning, executive dysfunctions, attention and concentration, conceptual reasoning, inhibitory processing, processing speed, visual perceptual abilities, integration of visual motor abilities, and emotional well-being, which is a key aspect of the assessment. So what's the purpose of the neuropsychological evaluation or testing? Well, it's to find obviously possible problems with your brain functioning that sometimes is not captured by an MRI, to clarify or confirm diagnosis, to define the brain-related strengths and weaknesses, and I will explain why the strengths are so important for rehabilitation purposes, and to guide the treatment for medical, personal, educational, or vocational kind of reasons, and to document also with continuous monitoring the changes in functioning over time, which will help your neurologist also assess the staging of your condition. Once we have the neuropsychological test results, we refer to this normative table to translate to you or to inform you of the classification or the extent and the degree of your cognitive deficits. So 50%, roughly, more exactly 68% of the population falls within the average range. And then as we go to the left of that table, we find deficits within the mild to severely impaired range, which require remediation or help. Then to the right of the scale, it's really what we call beyond the 81st percentile, your cognitive strengths from which you're going to use to compensate for your other deficits. So the treatment considerations for cognitive deficits in multiple sclerosis really has to do with being compliant with your treatment neurologically, with the disease-modifying therapies recommended by your neurologist. And then if you show to have memory impairments that are severe enough within the clinically significant range, then we recommend also for the neurologist to put you on some kind of anticholinesterase inhibitor to slow down the progression of your memory deficits. And there's also cognitive rehabilitation strategies that you can follow, and those are usually rely on compensatory kind of techniques to help you overcome those weaknesses, okay? So just like I explained before, when we have the test results, we actually use compensatory strategies to remediate for the cognitive deficits observed based on your performance and testing. One of the big ones is really to become a little bit more organized, which what we call is an aspect of executive functions. So we use personal organizers, those with alarms, written reminders, directions, phone logs. I use that myself, otherwise I would be completely lost in my daily activities. Pacing activities to manage physical and cognitive fatigue. As we know, fatigue is a big one in MS, especially later on in the disease. And also, you know, for your job's sake, you can use telecommunicating. If you're really not able physically to get from point A to point B, you can make use of those kind of resources to help you manage more your activities. What are some of the factors that interfere with cognition? Well, as we know, The first ones are tiredness and fatigue from a physical kind of standpoint, the amount of relapses that you have, and also the medications that you're taking. Sometimes we don't know that certain medications may be causing cognitive difficulties. So it's very important to educate ourselves and become familiar with those medications that we think may be causing significant cognitive difficulties. So in doing this, it's very important for you to have an open communication with your neurologist so that you can express to him or her the kind of cognitive deficits that you're experiencing, in case they can actually pinpoint this to any medication that you might be on. From a psychological standpoint, obviously emotional stress is a big one. Depression, the sense of inadequacy, self-esteem, self-confidence goes down, and anxiety. So these are big ones, because oftentimes I see patients that come into the office complaining of memory problems and forgetfulness. They can't remember things that they were told, or they can't remember events, appointments. And sometimes this is due to other factors that are not related to the encoding or retrieval, or at least that organic kind of circuit in the brain, and it's more related to our psychological functioning. So when we are depressed, we experience memory difficulties, and the processing of information is also slower. So it's not necessarily due to a memory impairment, but it's more due to how our emotions are expressing itself, because if we're feeling hopeless, sad, and anxious, you're not going to be able to actually encode that information from the very beginning. Why? Because it affects attention and concentration as well. We're distracted by these intrusive thoughts, and we're not able to encode the information effectively. Therefore, you're not going to be able to remember that information later on. So part of the assessment is also determining if that's actually a retrieval failure or an inattention failure due to your emotional kind of status at the time. Then also the treatment recommendations that we typically recommend is usually addressing your psychological symptoms first, because we do have to rule out that it's maybe due to a mood disorder from your medical condition or the MS, or it could be something that you're going through in your life at the moment, and it may be affecting already your cognition. So individual psychotherapy, most often we employ cognitive behavioral psychotherapy with a supportive kind of modality to help you gain insight, educate you on your medical condition, and then develop the coping mechanisms that you need to kind of deal with immediate stressors in life. We live in a very stressful world nowadays, and it's very easy to fall into this trap. So it's very important to address your emotional well-being first. Before we need to take care of that before we take care of other aspects. If you are down and depressed and very anxious, you won't be able to even engage in physical activity, which is what's recommended for multiple sclerosis or any kind of good wellness program. You have to do exercise, and if your mental status and your emotional well-being is not there, you're not going to be able to get up and do that. So it's very important to address that in individual psychotherapy. I recommend that before going the psychotropic or medication route with a psychiatrist, because those medications can also impact your memory, okay? So it's better to do it that way first, and then if you don't see enough improvement with psychotherapy, then I recommend medication for that, for the depression. Group psychotherapy as well, I find it very useful when patients belong to a community support system. Let's say the MS Foundation, the MS Society, or any kind of support system. I know at Memorial now we have a support group for patients with multiple sclerosis, and it's a great opportunity to network and actually kind of have a sense of cohesiveness, that you're not alone, okay? In case you have questions to ask, we go over coping strategies, the sleep patterns, emotional well-being. It's kind of like a good thing for you. So the more involved you are in these activities, the less likely you will experience depression and anxiety. And any questions?
Okay, so this is how we're going to do that. Sorry, everybody. Jennifer's going to run around this side of the room, and I'm going to go to the far side of the room. If you have a question, please raise your hand and let one of us get to you. We have to have you speak into the microphone, please, and then we're going to be doing this for about 10 minutes, okay, before we go to the next speaker. And by the way, let's give a round of applause to Dr. Broz.
Thank you. Thank you.
So I have the first question over here, please.
Yes, I'm wondering, there are a number of computer apps like Lumosity and all that say they're going to improve brain function. Have you found them to be successful or effective or not?
Absolutely. Yes. When we try to rehabilitate the brain or stimulate areas of the brain that we know have been lost or that we're progressively losing, it's important to engage in new learning. Okay, so when a task becomes repetitive and automatic, we don't see a lot of improvement, and it's not as beneficial. So anything that you think it's analytical, involves a lot of reasoning, and that you're learning something new, it's what we recommend. Okay, you're welcome.
Question over here?
Yes.
Yes, if medication is needed, do neuropsychologists give the medication, or do you have to go somewhere else?
Okay.
After the test results.
So, based on your test results, we see your cognitive pattern and emotional functioning, and we make recommendations to our referral physician. It's usually the neurologist. So we recommend to him if we think that your deficits are severe enough to recommend medication.
Thank you.
Other than Lumosity, which other apps do you find effective?
Okay, there is the Brain Neuro. There's many. Actually, there's many out there. I cannot think of the ones right now on top of my head, but try to find the ones that are more objective, where they have done a little bit of research studies on. So usually if you go to the MS Foundation or Society website, they have a list of these apps that you can log on to or become a member of that are usually good for you. But I tend to recommend a more a structured rehabilitation kind of program. And those are usually provided by speech pathologists. Speech and language therapists can actually help you with that.
Question here?
Yes.
For the resistance training, can you recommend any videos or anything like that that we can watch home and try to do the resistance training at home with our own walls and stuff like that?
Resistance meaning physical or resistance training?
Resistance training under
Okay, so that's a type of
combination.
physical exercise, like aerobic exercise, that can improve your physical kind of functioning. So I think you should address that with your neurologist or physiatrist, and they can actually recommend the exercises that are good for you for physical therapy.
Next question here.
Can metabolism and a change in your eating habits also have some kind of effect also?
Yes, absolutely. So what we know is that a nutritional program that is high in omega-6 and amino acids and proteins help you with your brain health. So definitely, a good nutrition can help.
During the test, are you able to tell the difference whether if it's an early stage of Alzheimer's disease or related to MS?
Yes. So part of the evaluation is actually to differentiate or rule out any other neurodegenerative conditions aside from the multiple sclerosis changes that we see on a typical profile for you. So yes, we will be able to determine that.
A question over here?
Yes.
You mentioned omega-6. What about omega-3?
Yes, all of the omegas are good for your brain health. So consuming nuts, beans, it's good for you.
I'm just curious in general, is there any programs that you could do at home to sharpen your brain?
Yes.
Video games, something like that.
Yes. So like I mentioned before, any cognitive ability that has to do with new learning, it's what we recommend for you to engage on. But definitely any games that you find mentally stimulating will be beneficial for you. Learning a musical instrument is very beneficial as well. Thank you very much, everyone.
All right, so our next speaker is Dr. Janice Cohen. And Dr. Janice Cohen is board certified in physical medicine and rehabilitation and is a fellow with the American Academy of Physical Medicine and Rehabilitation. She graduated from the University of Missouri, Kansas City. Dr. Cohen completed her residency in physical medicine and rehabilitation at Baylor College of Medicine in Texas. Dr. Cohen's area of specialty includes inpatient rehabilitation and electromyography. Dr. Cohen, come on up. There's the screen, there's the screen. Great, thank you.
Hi there, everybody. I'm delighted to be here today to talk to you all about spasticity. So, why are we even talking about spasticity? It's very possible that 8 out of 10 of you here with multiple sclerosis also have spasticity. And to break that down even further, there was one study that further categorized spasticity by severity. And in that study, they found that about 44% of patients reported moderate severity spasticity, and up to almost a third reporting severe spasticity. So spasticity is prevalent, and it's important for us to address it and talk about it. So how does spasticity happen? What happens in a normal functioning nerve communication system is here we have the brain and the spinal cord. We have an upper nerve communication system and a lower nerve communication system. The upper nerve communication system typically goes through the brain and the spinal cord and then interacts with the lower nerve communication system in turn to control our muscles, which is depicted here, representing the muscles of our limbs, such as our arms and our legs. What happens in multiple sclerosis is we get a lesion of the upper nerve communication system, such as in the brain or in the spinal cord. In effect, this causes a dysfunction of the communication system between the upper nerve system and the lower nerve system. So, whereas in a normal system, there would be a signal from the upper nerve system telling this lower nerve system to remain calm. In multiple sclerosis, you no longer have that signal, and so you get kind of this excitatory feedback down in the lower nerve system. So if we look at the textbook definition of what spasticity is, we commonly find these types of explanations. Spasticity is a disordered sensory motor control resulting from an upper motor neuron lesion presenting as intermittent or sustained involuntary activation of muscles, or quite commonly, a motor disorder characterized by a velocity-dependent increase in tonic stretch reflexes, which results from an abnormal intraspinal processing of primary afferent inputs. That's a lot. How I like to describe spasticity is by describing what I hear my patients describe spasticity as. So some of you, this may be familiar to some of you. They might say, "Doc, my hand or my arm, my leg or my foot doesn't do what I want it to do. My arm feels heavy. It feels like a Charlie horse that doesn't go away. I have constant cramps. I can't get into a comfortable position at night. It feels like stiffness or tightness." So what these are all describing is a constellation of symptoms in the situation where the nerve communication system has been disrupted. They can be on opposite ends of the spectrum, such as complete weakness or paralysis of the use of an arm or a leg, or loss of control. And then on the other end of things, overactivity of a muscle, spasms, or abnormal posturing, stiffness, and even pain. Spasticity itself is a manifestation of muscle overactivity. And again, I mentioned that on the opposite end of the spectrum, nerve lesions can cause weakness of muscle. Now, you don't have to have any of these symptoms singly. They can occur together. And even though they're on opposite ends of the spectrum in terms of their presentation, what can happen is if left unchecked or unmanaged, both of these issues can lead to soft tissue contracture, which is a fixation of a joint in a certain position due to changes in the muscle and the soft tissue, thereby leaving a joint unable to move. So as a rehab doctor, I really am interested in improving quality of life, and therefore I want to address the consequences of spasticity that negatively affect our quality of life. Persons with spasticity can develop things such as malodor from not being able to extend a limb away from the body or not being able to open up a fist, thereby having a constant state of moisture, which can also lead to skin breakdown. Skin breakdown can also happen from constant posturing of a limb, where a joint is constantly rubbing on something like a shoe or a chair. Spasticity can cause pain directly and cause injury to nerves by way of stretching the nerves. We talked about developing a contracture or a fixed angle of a joint, and also simple movement activities such as rising from a chair, which you all know all of these, rising from a chair, walking, using a toilet, as well as things that affect quality of life due to sexuality and interpersonal relationships, negative body image, as well as ability to participate in leisure activities or work activities. So these are common presentations of spasticity. It's possible to have a combination of these or only one. Some of these tend to be a little bit more severe depictions of spasticity, but you can see why it's common to have malodor in somebody who has a fist that does not open, or to have a nerve stretch injury in an elbow that's constantly flexed or a wrist that's constantly flexed. In the lower limb, which one study has pointed out may be more affected in multiple sclerosis than the upper limb, it's also common to see these types of positioning, and you can also see here why one might develop skin issues. For instance, if the toes are constantly curling under and possibly rubbing on the top of a shoe, or a hitchhiker toe is what we call this, and that's, my apologies, a striatal toe, there's a typo there, developing possibly skin problems at the top of the toe. But not all spasticity is bad, believe it or not. Sometimes spasticity can help us maintain muscle mass and decrease the risk of osteoporosis. It can help with blood circulation. Sometimes it can even aid in emptying the bowel and the bladder, but oftentimes we see it doing the opposite and in inhibiting bowel and bladder emptying. It can aid in posture or help with positioning with different types of movement changes, whereas one might not be able to move at all with a paretic limb. They might be able to do a certain movement with that muscle tone. So spasticity can be challenging to treat, and our goal is our goal and treatment are aimed at managing your symptoms. PT and OT remain a mainstay of our toolbox of tools to help manage spasticity. But also we have oral medications, injection medications, even intraspinal medications, and sometimes surgery. And of note here, surgery should really only be considered in cases of severe debilitating spasticity. So some medications may be familiar to you all. Tizanidine or Xanaflex, baclofen, Valium or diazepam, gabapentin or Neurontin are all aimed at kind of modulating that central nerve system that we talked about earlier when I showed you that picture of the brain. And We also have some agents that act more directly at the muscle to cause muscle relaxation, such as dantrolene sodium. Oftentimes, these medications are limited by their side effects because they are acting centrally. I quite often have to stop medications because of cognitive impairments, such as what Dr. Broz mentioned, as well as drowsiness and sometimes even excessive muscle weakness. So what we have available, if patients cannot be managed solely with oral medications, or sometimes they have benefit with oral medication, but they could use a little bit of extra something else, we have botulinum toxin, which is an injectable medication. Botulinum toxin is derived from the Clostridium botulinum. There are 7 serotypes, but we use 2 of them that are FDA approved in controlling upper and lower limb spasticity. The advantage in botulinum toxin injections over oral medications is that they can be delivered directly to the muscles that are affected, as opposed to the oral medications, which may cause those symptoms such as drowsiness and cognitive side effects that we don't see with the injections. Botulinum toxin acts to inhibit neurotransmitters from sending signals to the muscle. So here we have a nerve and a muscle cell, and these little signals are often released in a normal functioning interface here, and telling the muscle to activate. So what happens is Botox prevents these little vesicles from attaching to the nerve cell wall, and thereby inhibiting the release of little signals, and therefore causing muscle relaxation. Botulinum toxin is administered in the office. We do it with a localization using an EMG machine or nerve stimulator, and oftentimes also an ultrasound machine. It's given through a syringe directly into the muscle, and it does not require sedation. There's another type of injection that's available to us called phenol, sometimes alcohol, which is also given as an injection. It's actually not a drug, it's a chemical, therefore it's quite cheap to come by, versus botulinum toxins, which are quite expensive. The disadvantage of phenol injections are that they can be technically more difficult to administer. What's happening in phenol injections is the needle is going right to the nerve to cause a sort of chemical burning of the nerve. So that can be quite a tedious procedure, versus botulinum toxin injections in which the injection goes straight into the muscle, much like you would get a flu vaccine shot. The onset is immediate as far as seeing the results of phenol injections, versus with botulinum toxin, it can take several days to a couple of weeks to start seeing muscle relaxation. With phenol, the injection can be done quite soon thereafter the initial injection, but with botulinum toxins, these cannot be administered more than every 12 weeks. With phenol, the efficacy or the length of time that you see muscle relaxation can be 3 to 6 months, sometimes even more. But with botulinum toxin can be sometimes only several weeks to months. Side effects are similar for both of them because it is an injection. The needle can cause pain, bleeding, or infection. But particularly with phenol, one side effect that to consider is possibly painful sensations because of the nature of the injection going straight to the nerve. When we've tried oral medications and injections and we're still not getting much of a desirable effect, we can move on to considering intrathecal baclofen or intraspinal baclofen. So intraspinal baclofen, much like oral baclofen, does work to modulate the nerve communication, but with less side effects than if given orally. I'm just going to briefly go over this. Dr. Jackson Cohen might go over this more in detail later, but what this is the apparatus that holds the intrathecal baclofen. So the liquid medication is placed in this reservoir, which is then implanted under the skin in the abdomen, and then a tubing system is connected to the port and surgically threaded into the intraspinal space to deliver medication. When a patient needs a refill, one simply comes into the office and a syringe is inserted through the skin and into the reservoir to refill the medication. So we talked about how not all spasticity needs to be treated. Some spasticity is good. But just because you have spasticity does not mean we have to address it, does not mean we have to treat it. When we find that we do need to treat it and it's affecting the quality of life, we do need to involve not only you as the patient, but your caregivers, your family members, and anybody in the treatment team that's involved in taking care of you and your condition, such as your neurologist, your primary care physician, your therapist. And then most importantly, we have to ask, what is the goal of the treatment? Goals can be anywhere from, ranging from controlling your symptoms of spasms or decreasing pain, to being able to move a limb, to be able to put on a shirt, or to move an ankle, to be able to put on a brace, or to allow for a little bit more activity, as with walking. So for instance, if somebody has spasticity causing dragging of the toe, we might want to focus our efforts on controlling the muscles that are causing that toe to drag while they walk, so that they can avoid potentially falling or any wound issues that might occur from constantly dragging your toe on the floor. It's important to constantly reassess the treatment goals and the treatment plan to see if what you're doing as an intervention is really addressing what the goal was initially. PT and OT, I mentioned before, are the mainstay of our toolbox for treating and managing spasticity. PT and OT can utilize a whole host of different types of methods to control spasticity, including stretching, ranging the limb, going through range of motion, splinting or bracing, as well as things like cryotherapy and hydrotherapy in some situations. So I think we wouldn't be complete in talking about methods to manage spasticity if we didn't address this sexy topic of cannabis for treating spasticity. There are two big studies that I wanted to share with you regarding how we can use, or the potential use of cannabis for spasticity. One of these studies was a big review from the American Academy of Neurology, and what the AAN did was look at a whole bunch of studies dealing with certain neurologic disorders, including spasticity, and they happened to include patients who had MS, and they really narrowed it down to certain criteria. And what ended up happening was they ended up grouping these patients into 3 different treatment groups. So one treatment group received a medication called nabiximols, also known as Sativex, which is an oral mucosal spray, which is a combination of THC and cannabidiol, and it's not available in the US. The other treatment group was oral cannabis extract and THC, and then another treatment group was smoked marijuana. So what this big study found of multiple studies was that 2 of these groups, the nabiximols group and the oral cannabis extract and THC group, showed that patients reported improved symptoms of spasticity when they received these interventions. But interestingly, when you looked at objective findings, there really was no significance. And then with smoked marijuana group, there was not enough information. So another big study that we had was involving spasticity due to MS or paraplegia, but most of these studies involved patients with MS. And again, they looked at different study groups. This one has a little bit more than the last one in that it involves patients who received synthetic cannabinoids, which we do have available here in the US. And they compared it to patients who did not receive anything. They found, again, like the other big study, when you ask patients subjectively if their symptoms were improved, the answer was yes, but objectively, not significant findings. So in conclusion, most of these studies suggested that cannabinoids associated with improvements in symptoms, but these associations did not reach significance in all the studies. And there was moderate quality evidence, so not mild and not strong evidence, to use some of these agents to manage spasticity in MS. What the AAN wants you to know is a couple of things. Sativex is not available in the US, and it's not FDA approved in the US. And also, caution should be used to extrapolate or to use this information to other forms of oral cannabis or other forms of cannabis medically that are available here in the US. So in summary, spasticity is common, can be debilitating, should be addressed. And even though it is difficult to manage and treat, the multimodal, multidisciplinary system remains a mainstay of how we manage and treat spasticity. Thank you for being an awesome audience.
Great, thank you. Thanks, Dr. Cohen and Memorial Healthcare System for doing this again. All right, so again, we're going to run around the room again. Jennifer's on that side of the room. We're going to crisscross back and forth. We only have 10 minutes of time to do these questions. So who's first up on the left? Thank you.
How does the baclofen pump actually work, and how do you know when it needs to be refilled?
So the question, I don't know if everybody heard, how does the baclofen pump actually work, and how do you know when it needs to be refilled? The medication is in a liquid form, and and I showed you a picture of the reservoir that's implanted. So the medication actually gets pushed into that tubing into the spine, where it acts in the same way as an oral medication, but it just diverts its pathway directly to the nerves, rather than having to take a pill and having to go throughout the whole body system. There are alerts when you know it needs to be refilled. Everybody's a little bit different as far as what dose they need. Over a certain amount of time. So based on, it's a very specific dose. So based on that dosing, we know about when the little reservoir is going to need to be refilled, and there's also alerts. So that's often done quite well before you would run out of the medication. How often does it need to be refilled? Again, it varies per patient. Some patients need a lot higher dose. There's different concentrations also. So if somebody is needing quite frequent refills, then there's a possibility to change the concentration also of the medication.
Great. Question over here.
Hi. Although I take Neurontin, which obviously doesn't affect your brain, Xanaflex is obviously an issue because if you plan on functioning, you can't take it. Many of the insurance companies limit the amount of PT visits that you can have in a year, which is like hysterically stupid. And because of that, out of pocket being so expensive, I was curious about what your thoughts are on things like stretch zone and Thai massage and things like that might be more cost effective.
Those are good points, and your frustrations are our frustrations as well. With regard to traditional physical therapy and occupational therapy, I say for the other things, go for it. If you find that it helps you and it is more cost effective for you, then by all means do it, as long as it's not hurting you. There are, and Dr. Mehta might go into a few more of these types of interventions in his talk, but there are a lot more things out there than the traditional PT and OT that we should use in our toolbox. You're welcome.
Do you know of any over-the-counter or herbal supplements that are effective for spasticity?
Other than the medical cannabis, which we kind of touched on, which I'm not promoting, anything that you can get that's available here. We only have looked at the tip of the iceberg with these studies. No.
I have a question over here.
Do you, in your practice, recommend any other type of integrative therapies? Like you mentioned massage, but what about acupuncture for spasticity?
That's a good question. I've had patients use it, and again, I'm going to probably refer you on to the next speakers who might be able to touch a little bit more on that.
Okay, next question here.
Can the baclofen and Botox be used together? And if they can, when do you choose to use the Botox with the baclofen at the
That's
same?
an excellent question. Oral baclofen and intrathecal or spinal baclofen can be used together with Botox. They have two totally different mechanisms of action, and quite typically we are limited with how much botulinum toxin, and you used one of the brand names, which is Botox. We're quite limited with how many units total we can use, and sometimes if you've got spasticity all over, we just don't have enough units to use all over. Quite frequently, we will use a combination of any of those medication treatments I mentioned, but also botulinum toxin or Botox with the baclofen pump or oral baclofen.
I'm going to ask what I think is maybe a funny question, and I apologize. It's maybe a professional opinion for you or someone else. This Thanksgiving will be 20 years for me, but I have a condition where I'm getting a spasticity in my lower legs and all that, and cramps, which I've never had younger in sports. But another symptom that I'm having that's getting progressively worse, and I don't know if you've ran into this or if it's even related to spasticity, but it has to do with a clumsiness. I'm finding when I'm going to either pick something up or to put something down, I'll get like a nerve reaction. And it's to where even when I'm in the kitchen, I just prepare things inside the sink because I know I'm going to make a mess. Is this spasticity or what is this?
Not per se, but commonly referred to as spasticity, but it falls under that umbrella of that upper nerve communication injury. And then obviously there's a lot of more factors that will play into this regarding what the actual medical treatment plan is. Yes, but clumsiness, but clumsiness can be a manifestation of not so much spasticity per se, but interruption of the nerve communication that we talked about earlier.
Great. Next question over here, please. Over here.
Hey, everybody. Kind of working off of the gabapentin and Botox question, but a little bit more general. When we're dealing with gabapentin and baclofen, that they trigger certain parts as far as pain relief, in the different areas. Is there anything that we know of so far besides the different treatments that would help maintain functionality? That's it.
So all of these tools are what we use to, so to speak, try to maintain functionality. And there's not one right answer. We often use a combination of these, and that's why I mentioned several times it is kind of difficult to try to say we treat it, and we try to manage the symptoms and try to keep you as functional as possible. As a rehab physician, that's one of our main goals is working towards maintaining function as long as possible.
Couple things. I spoke to my brother in California. With the MS, I also have back problems. We're walking and things like that. You're talking about injectable baclofen or having a pump. What about stem cell in the back? I know they can't do anything with MS, but in the back, I'm hearing that they've been pretty successful with stem cell in the back for treatments of the back.
So you're talking about stem cell treatments for spinal lesions?
Well,
with regards to multiple sclerosis?
For the spinal area. In other words, I've had MS for almost 30 years, so my back is all over the place. And
Yes.
I think it adds to my MS.
Right, and that's a hot topic, of course, that I don't have the answer to that question in particular. I know there are, as we talked about, a lot of studies out there with regard to stem cell, and there's lots of different types of stem cell treatments, but it's not anything that's translated into a bona fide treatment option at this time.
Okay, the other thing I'd like to say real quick is that my mom, I have had MS in the family probably about 40 plus years, whoever it is. And what they've evolved over the past years has been a lot. And it's very frustrating for everybody, but it's evolved and it's going forward. and it's not Rome's not built in a day. So just keep the faith, and it'll happen.
Thank you.
Thank you.
Thank you.